there's no kata apa, there is no kata apa, tak ada standard skin exposure for sunlight anyway, but it should be enough with the arms and face lah. So that there is no such standards in terms of what to expose. So in terms of your arms, and people says a bit more of the legs and the face, that should be enough. You don't need lah. Kalau macam Mak Saleh kan dia suka sunbathing kan, so but you don't need the whole body for exposure. Just briefly, arms and face, bit of legs, over 10 to 15 minutes. That should be enough. Okay, so let's start with Kitab Al-Fatihah. Okay, so the long case is going to be a simulated long case. So I'll give you the scenarios. So from the scenario, what you need to do is you need to basically just try to expand furthermore in terms of what question that you want to ask, depending on what is your differential diagnosis. So obviously, the longer the more different differential diagnosis that you have, there will be more questions what you want to ask. Okay, so the reason I give you a very short history there, so that you can think about about plenty of more diagnosis. So the longer your diagnosis will be, the more questions you want to ask, and I'll give you the information based on your question. So the plan is that one student going to lead one case, so it should be 2 cases, so 2 students going to lead the case. Okay, so who's going to do the first case?
It will be me, doctor.
Okay, fine.
Can I share the case scenario that you give to me?
Yes, you can.
Everyone can see the case scenario?
Yes.
Okay.
Yes.
First, I will read the case first. Farah is a 6-year-old girl who presents to the A&E department where her mother states that the Farah urine has turned red. She has brought a jar of urine which contains that appears to be reddish brown urine. She has no dysuria, frequency, or abdominal pain, and there is no history of trauma. She is otherwise well, but she and the rest of the family had recently had colds. There have been no nosebleeds or abdominal bruising. She has had no problems with her joints. She had a urinary tract infection at the age of 4 years old, but following a normal renal ultrasound. And she was discharged from the clinic for follow-up. She is on no medication. There is no family history of renal problems, but her grandmother has hypertension. Okay, from the case scenario, is there anything that you guys don't understand from it? Okay, I take it as no. Okay, based on the case scenario, what is the cause for the hematuria, and what is the further question you want to ask based on the causes? Okay, if there is no response, I will pick someone. Shafatin, what do you think the cause for the hematuria, and what is the further question that you want to ask? Shafatin. Hello?
Yes. The cause could be due to renal pathology.
Okay. And then what is the further question that you want to ask? And what is the specific cause for the renal pathology?
So I would like to ask, is there any maybe loin pain,
Okay, for the loin pain, what do you think the child will have if she have a loin pain? So,
Hmm. Kejap.
so I think you think about a renal stone, right? Because have a loin pain.
Yes, yes.
Okay. 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 Next, Aziz, what do you think of the other causes for the hematuria? And what is the further question that you wanna ask?
Um, so I'll be thinking about if there's any infections in the urinary tract or in the urinary bladder. So I'll be asking about any fever. Perempuan kan? So
Yes.
yes.
So you are thinking about the urinary tract infection.
Yes.
Okay. Okay. Other causes that you guys can think?
Trauma.
Okay, trauma.
Nak
But in
tanya apa kau trauma?
this scenario, the mother said that she have no history of trauma.
Oh, okay.
Post-infectious glomerulonephritis.
Okay, for that causes, what are the other question that you want to ask?
I would like to ask because the whole the whole family have recently had colds. So I would like to know if they have been anywhere either outside inside Malaysia or outside Malaysia, so that we can know what is like endemic in the area, so we can figure out what causes the cold. And then aside from that, I would like to know other glomerulonephritis symptoms, such as if there is any facial puffiness or lower leg swelling. What more? Oh, and then I would like to know if the urine is frothy or not. Satu, dua. And has Farah had been having headache or any blurry vision? Okay, so that's
Okay. Furthermore, we also can ask whether Farah, the frequency, the volume of the Farah, whether she have polyuria or oliguria. Okay, thank you, Fatin. Okay, first now, Chapatin has suggest renal stone, and Aziz has suggest UTI, and Fatin has suggest PSGN, and there's only three. So you guys can suggest more other differential diagnoses. We at least need 5 differential diagnoses.
Can I suggest?
Okay, and
Okay, because this patient come with hematuria, can we think about bleeding disorder? For example, first thing, maybe due to coagulopathy like hemophilia. But this patient does not have any problem with her joints, because we know that hemophilia usually come with hemarthrosis. And then we also can put as ITP, idiopathic thrombocytopenia, as the diagnosis of exclusion.
okay, thank you, Cik Alif. Is there any other differential diagnosis that you guys want to add?
Tumor ada semua.
How about HSP?
HSP, yeah.
Yeah. What is the further question that you guys want to ask if you guys suspect that she have HSP?
Can we can ask the mother if there any skin lesion or skin rash, and then sign of symptom of edema, and then for the rest it might be palpable, rest hemorrhagic, and then but however, as as in the history, there is no abdominal pain and also what you call joint pain. No
Yes.
problem with the joint. Okay.
Okay, thank you, Faizal. What is this other question, especially for a girl at this age? Specific for the girl, what is other differential diagnosis that?
LE, lupus nephritis.
What?
Lupus
Yes,
nephritis.
SLE.
Kalau menses awal sangat kan.
So, yes, menstruation. So we can ask, but what is the name of the if a girl as the age have the menstruation?
Apa?
Yes, precocious puberty.
Precocious.
Precocious
puberty.
And, can someone state the definition of precocious puberty? Basically, the idea.
The idea is that the precocious puberty is when the children experience signs of puberty earlier than the normal age that usually people or usually normal range of puberty, normal age of puberty.
What is normal age for a girl to get a puberty, to reach puberty?
9.
Okay. Which is precaution is before 8 or 9.
Before
8 or 9.
Okay. So just now we already have about 8 to 7 this patient diagnosis. But based on this all of these differential diagnosis, what do you guys think the most common for a child to get hematuria? Which is the common one?
Infection.
UTI.
Yes, UTI. So for further questioning, what you guys want to ask at the mother if you guys suspect UTI?
Does the patient have any fever?
Okay, true. Other than that?
How's the condition, the hygiene care of the children?
I think okay. What are the question that you will ask about? Okay, especially about the urine.
Any other urinary symptoms such as dysuria, incomplete voiding?
Okay. So you want to ask about the LUTS, right? Lower urinary tract infection. Other than that, for a child, yes, for smelling, the mother might notice that there is a changes in the smell of her child urine. Other than that, what about the color? What usually gaudy? Yes, gaudy. And other than that, in the children, when he or she have a UTI, what is other symptom?
Is it bedwetting?
What?
Bedwetting.
So what is the first question that you want to ask before you ask about the bedwetting?
First question.
Before you can say that this her child has a before this is okay. First question that you want to ask is about her urinary habit, which is tanya, kita kena tanya bila adakah anak dia ni sebelum ni memang selalu kencing malam ke? So tanya dia whether if we ask her whether her child is dry by day or dry by night. So tiba-tiba suddenly about a past few weeks dia selalu kencing malam. It suggests that child might have a problem with the urinary habit. Okay, thank you, Amali. Okay, other than that, other question that you guys want to ask?
Any history of going to public place, public swimming pool? Is that
what
valid?
you want to ask that?
Because when when they go when they went to any places like swimming pool, public, and then that have no, the clear sense of no pollution, no, not polluted place. So it's kind of like the hygiene kind of thing, because the woman genitalia is like very short, and the urine tract is very short, so it's very easy for infection to occur.
Okay. Hmm. Okay. What is okay? For the, one of the other symptom that the child can get during the UTI is what we call he or she doesn't know what to say, that he will vomit. What we don't, nausea and vomiting. So the child might want to vomit, but dia tak reti nak cakap dan dia tengah nausea. So these other symptoms in the UTI. Okay, I think that's all for the UTI. Okay, for other differential diagnosis, which is renal stone. What is other question that you guys want to ask? Khadijah?
Any sandy urine? There is any deposition in the urine?
Sandy urine. So it means that it's a stone-like formation in the urine, right? And others, people also accept there will be dysuria. And for HSP, what are the other history that you want to know before you want to exclude or diagnose this patient have HSP?
URTI syndrome?
Okay, I didn't know that.
Can I try?
Okay.
HSP can affect about 5 system, if I'm not mistaken. The first one is dermatology system, which is the HSP may develop rash. Then the second one is musculoskeletal, which is it can cause joint pain or joint swelling to the patient. The third one is renal, which is can give the symptoms of hematuria. And the fourth one is GI system, which it can cause abdominal pain or any bleeding such as melena. And the last one is CNS. However, this is very rare. And for CNS, we can ask about the nausea and vomiting or any history of seizure. I think that's all.
Okay, thank you, Amaline. Okay, other than that, as you can see in the case scenario, why in the case scenario, there has mentioned that there have been no nosebleed or lumbar bruising, and also there is no joint pain. So this to exclude?
HSP.
Yes, to exclude HSP. Other than that, what is other problem that we can exclude from this statement?
She has no dysuria.
Based on this statement, yeah. So what is other differential diagnosis?
To exclude coagulopathy,
Okay.
bleeding disorder.
Yes. Other than that, multi-organ. One diagnosis that involve multi-organ. Yes, SLC also can be excluded because in SLC there will be a certain patient that will develop thrombocytopenia, right?
Yes.
Okay, I think we have covered a little bit about on the history that we need to ask for all the differential diagnoses. So, what is other further question that you want to ask in the history? how about the we ask about the complication of, for example, like HSP. So we can ask about the abdominal pain. Maybe we suspect the patient have and also ask about the stool characteristic, because HSP can lead to development of intersection, right? So we might to ask about the stool color of the child, whether it's red or jelly in nature. And other than that, we also might, yes, how many?
Teruskan. Cakap dulu lah.
Okay, no, you can say what you want to say.
Okay, maybe we can ask about history of constipation, because in children, constipation may cause UTI.
Can you explain more why constipation can cause UTI?
In constipation, it can cause full rectum. So this full rectum can block the outflow of the urine, and it can cause urinary retention. So when there is urinary retention, it can cause colonization of the bacteria, and consequently it can cause UTI.
Okay, thank you, Amalie.
You should say it's bacteria colonization of the urine, not the colonization of the bacteria, because bacteria colonize any something. It's not that something colonized by bacteria.
Okay, thank you, doctor. Okay, as we mentioned before that UTI is commonly in the children, right? So what is other question that you want to ask? So for me, I will ask about any comorbidity that lead the child to have UTI. Okay, first, what is the comorbidity that she might have that we need to ask her mother? Anyone?
Any congenital abnormality such as PUJ, vesico-ureteric reflux.
Okay, true. Other than that, Aziz? Other than VOR, PUJ?
Predisposed condition.
What?
What's the question again? The abnormality?
Comorbidities that impose the patient to get UTI. Amali has said VUR and PUJ. Other than that,
I don't know.
Okay, what comes in my mind, if the child is a boy, it may predisposed to get UTI due to formation of hypo or epispastia. Hypo or epispastia. So and also there might be due to posterior valve urethra, and we can read it in the PITS protocol. Also hydronephrosis.
What caused the hydronephrosis? Is it like the condition where there's a backflow of the urine?
Yeah.
So there's a blockage, obstruction, urinary tract obstruction, is it?
Yes, there will be urinary tract obstruction, and the causes might be due to repeated UTI, lead to scarring.
Right.
Okay, Fatin just now mentioned about PSJN, right? So she mentioned that we need to know further about the code. So for the code, I think for this patient, I think we need to know when is the what is the duration of the cold, whether it's last week or last 2 weeks, right? Because as we know in the PSGN, it's due to the formation of the immune complex, which is due to molecular mimicry, right? So it needs several 1 to 2 weeks to develop into formation of streptococcal glomerulonephritis after the streptococcal pharyngitis or skin infection. So we need to further ask about the cold, whether it is a severe or just a mild cold. And then I think that's all from the history and the complication that we might think. Doctor, do you have any comment?
Okay, so you're talking about a 6 years old with hematuria. Okay, so so you will have your own kind of like your differential diagnosis. You're talking about UTIs, talking about glomerulonephritis, you're talking about calculi, trauma, you're talking about possible hematological conditions like hemophilia. And obviously, hemophilia probably slightly unlikely in this case because this is a girl. The thing is, mana macam UTI benda yang kau cakap tadi in terms of dia punya dysuria, frequencies, incomplete voidings, you're talking about fever, any abdominal pain or suprapubic pain, reduced appetite. 6 years old, if they got nausea, probably they don't really say that they got nausea. I would say they probably have reduced appetite. Because they feel nausea, they don't want to eat, so they normally come with reduced appetite, and also vomiting normally for UTIs. Whether the previous UTI at 4 years old is significant or not. So you want to know if somebody got UTI before. You want to know whether the child had any positive urine cultures. Okay, because nowadays you see a lot of people has recurrent UTIs, but when they say recurrent UTI, what does it mean by recurrent UTIs? Does it mean that they got symptom of UTIs, fever, and then they've been given antibiotics and they got better? Okay, so you should know that if somebody got UTI for 10 times, you want to know, does the 10 times UTI that they have, do they have the positive urine cultures? That's one thing. Well, before the urine culture, you want to ask, does they have positive urine dipstick or positive UFAM? And kalau UFAM ada leukocyte nitrate, then that's probably it is HI, even though the urine culture might not yield any bacteria. But if every single urine culture that they sense they have a positive bacteriuria, then it means that it is a confirmed UTI. Okay. Sebabnya kalau dia ada UFAM je, yang positive urine dipstick, tapi dia punya urine culture dia negative ataupun tak ada growth, then it's not a confirmed UTI, it's just a possible UTI. So you need to make sure that if they got 10 episodes of UTI, what is the result? What was the evidence that every single episode they have is a UTI? Because UTI by definition is a symptom with a positive result, positive urine result. Kalau dia cuma ada symptom je, tapi urine culture tak ada no growth, then it's not a confirmed UTI, it's just a possible UTI. Okay, so you want to know, mana kalau dia ada UTI before this at 4 years old, you want to know was it tested for urine culture. Kalau it's not tested, then it could be just a possible UTIs. So that's one thing. Talking about UTIs, and then you're talking about the post glomerulonephritis. So you're talking about preceding illness. So in this case they got URTI, which is probably common in post AGN. But what is other causes of what is other renal causes that can cause hematuria? So it could be IgA nephropathy. Okay, so how do you diagnose IgA nephropathy? Obviously you need to get you need to get the renal biopsy lah untuk diagnose IgA nephropathy. Cuma in terms of presentation dia, it's not much different to other presentation of hematuria. It's the same thing. Cuma the further question I want to ask is it really hematuria? Is it bright red color of the urine? Is it fresh blood? Is it clot in there? So you want to go further questioning of what actually parents find, mothers find in the urine. Okay, is it actually tea colored urine or Coca-Cola colored urine? Then? So normally kalau IgA nephropathy, it's not really hematuria. It's more of the very dark colored urine. Okay. You probably want to ask a question about myoglobinuria, because myoglobinuria sometimes can give you slightly red colored urine, tapi not really very red lah. Dia lebih kepada color macam tea color lah, macam air teh kan, teh obeng kan, teh obeng color kan. Ya, tak tahu lah ni Aisyah minum apa ni? Minum teh o ke minum tarik kan. Aziz makan apa Aziz?
Teh.
Air kosong. Aziz makan apa tu? Mulut munyah ni.
Bihun.
Makan bihun. Tak share pun. Okay.
Amboi.
Itulah. Patutnya kena share lah, makan seorang ni. Okay. So sometimes myoglobinuria also can come with kind of dark colored urine or sometimes red colored urine as well. But obviously myoglobinuria come with other symptoms macam muscle weaknesses, power dia low. Sometimes they come with gait problem and so on. So those are the different kind of pathology. But because of the myoglobinuria, so mana dia punya muscles dia breaking down. So breaking down of muscles, the myoglobin tu, then excreted in the urine, and then it causes the dark colored urine or tea colored urine. Okay, so those are your question. Tapi obviously your question will be depending on your differential diagnosis lah. And then for the question you're talking about hemophilia, and obviously in this case it's probably unlikely because hemophilia tend to be boys compared to girls. So and then more of the spontaneous bruising normally come. Mana selalunya dia akan datang dengan spontaneous bruising or spontaneous bleeding in the joints, hematosis, and rarely it comes with hematuria, but it's not possible. It is still possible to have that kind of thought, and then you can ask for the question about hematological disorders. So easily bruisings, if he get a cut ataupun luka sikit, does it take a long time for the bleeding to stop? Any previous episode of bloods in the joints, any episode of blood in stools and so on. So those are the questions about bleeding disorders. And then you rightly says about trauma and the history of trauma in the loin and so on, and plus family history of calculi. Calculi is very important, and sometimes urine infection also can cause calculi as well. And so what kind of bacteria is yang commonly associated with calculi, if you guys know?
Proteus.
So it's Proteus and Proteus species. So Proteus species. So if somebody, if a child come to you and the child confirmed to have calculi, okay, the first thing you want to test is test the urine to make sure there is no Proteus in the urine. So if there is Proteus, then you want to treat the urine infection, because it could be the UTI that actually caused the calculi. And then apart from that, you want to talk about does the child has any previous history of anatomical causes? And so kalau dia mungkin maybe ada polycystic kidney disease ke ataupun very severe hydronephrosis, sometimes it also can cause hematuria, because this anatomical malformation, sometimes it can make your blood vessels burst a bit, or something it can have a shredding of the urinary tract linings that can cause the bleed. So that could be the reason as well. But obviously if the child got anatomical malformation from before delivery ataupun memang ada at birth congenital one, then normally they will have more problems in the early stage of life compared to now 6 years old. So past medical history will be very important to us in this case. And sometimes one of you mentioned about tumor. And so what is the most commonest tumor that can cause hematuria in children?
Wilms tumor.
Okay, so kalau Williams tumor, what age normally you see? What is the peak age of hematuria in Williams tumor? Oh, sorry, what is the peak age of the child yang ada Williams tumor? Is it above 6 years old, 6 to 9 years old, more than 10, 2 to 5 years old?
Less than 6.
So it's much more younger age, probably about 2 to 3 years old normally. They normally come with the painless hematuria. So they got hematuria, and then the child never complain for any pain. And obviously, when you see the child might have abdominal mass. Then you can see the palpable mass, and sometimes parents don't notice this mass until they got hematuria because it's painless mass. Okay, so in that particular case, you just do ultrasound scan, do a biopsy, and then you might want to remove the kidneys that is affected by the Williams tumors. And obviously, family histories. I'm not so sure what kind of family history that can give you hematuria. If you got Potter syndrome ataupun Alport syndrome, so Alport syndrome also can cause hematuria as well, but it's a very rare occasions. Medications. So you want to ask about medications as well. So there's few medications that can cause hematuria. For example, and if you know,
Cyclophosphamide.
Cyclophosphamide lagi? Rifampicin lagi?
NSAID kadang-kadang boleh.
Okay, NSAID or aspirin also can cause that as well. So you want to know whether this child has been on any medications. Okay, so it's very important to ask about drug histories. Okay, so I'm just going to show you my slide. Present. Can you see my slide?
Yes.
Yes, doctor.
Okay. So this is the history, which is fine. So this is the physical examination. So basically, this child has no anemia. She's not febrile. She's got no rash, no skin rash, no bruising. There's no edema. There's no abdominal signs or joint problems. And also BP there 124 for 80s, and there's no other signs. So what you will make from this physical findings?
BP normal. Apa benda kau ni budak?
Hey.
Fatin.
Fatin of.
Ni bergaduh siapa tu? Okay. So siapa tadi? Hafiz.
Hafiz.
What can you made up from these physical findings?
Normal, not anything significant.
Okay. What about the BP?
BP, I think for the child we need to look at the BP chart, BP centile.
Okay, so at the moment you don't know whether the BP is a normal BP or not, and so you need to know the height and weight and then plot on the BP charts. But in general, this examination is normal. so no significant findings at all. So you basically kind of like saying that so are febrile, so are paroxysmal, so it's probably not really UTIs. There's no skin rash, there's no bruising, so you kind of ruling out ITPs, HSPs, or other hematological disorders or bleeding disorders. No edema, kind of like saying that this is not really HSPs or nephrotic syndromes. And the thing is, sometimes if you're talking about acute glomerulonephritis, well, sometimes they can have a bit of edema, and even though it's not as significant as nephrotic syndromes. There is no abdominal joints, so no abdominal signs, so there's no joint abnormality. So this is kind of ruling out in HSP as well. And the BP, so the BP is basically you just need to plot them. So if this is high, then this patient probably need to be on antihypertensive medication, try to control the BPs. Okay. So further investigation. So what investigation would you like to do?
First, I would like to do a blood investigation, full blood count.
Okay.
To check for any sign of fever, anemia. Look at the total white cell and red blood cell, hemoglobin level, and also look at the platelet level.
Okay. Anything else?
Okay, Faizal, anything else you want to add? Other investigation?
Do renal profile.
Okay, renal profile, what? What you want to see?
So yeah, creatinine level. And then we can do liver function test just to make sure as a baseline, or to detect any liver abnormality which can cause bleeding. And then we can do kidney UB as well.
Okay. Okay. So basically, obviously the investigation will be depending on our deficiency diagnosis. So you're talking about, if you think about this is infection, then full blood count with renal profile and CRP will be helpful. If you think about infection as well, then you can send a urine, FEM, also urine microscopies and culture. If talking about glomerulonephritis, then obviously you need to do further testing lah. Maybe you want to do ESR lah. You probably want to do ASO3, ANA to make sure this is not exactly nephritis, and you want to make sure that that you send also for red cell CAS. Mana kalau ada cell CAS present, then this is probably renal involvement yang menyebabkan dia ada hematuria. Okay. And sometimes you want to make sure this is not a mixed picture of nephritic syndrome. So you probably want to do C3 and C4 as well as part of your investigation to rule out nephrotic syndrome. And obviously kalau ada protein in the urine, then you probably want to do more tests for LFTs, and also you want to do the urine 24 hours of protein. And you want to do the cholesterol ataupun lipid punya assessment to make sure there is lipid yang no hypercholesterolemia. Okay. So in this case, what is your most likely diagnosis, Hafiz?
It most likely will be AGN.
Okay, so early will be AJN. Okay, so kalau AJN apa treatment eh?
What is it?
If you think this is post-strep AJN, so what would be the treatment?
The treatment will be
okay, if you that's fine, you can always ask your colleague to help you out.
okay. I will ask Amali what is treatment for AJN.
Maybe penicillin B.
So you want to give penicillin V for treatment of post-strep AJN.
Yes. Or erythromycin.
Okay. So why does post-strep AJN need antibiotics?
To eliminate beta hemolytic streptococcal infection.
Okay, so if you eliminate streptococcal infection, does it mean that the post-strep AJN will resolve?
No, not really.
Not really.
Because the AGN is mainly caused by the immune
Due to
complex.
immune complex deposition.
So the antibiotic is not the treatment for post-strep AJN. So is it antibiotic treating the AJN or antibiotic just eliminating the strep?
Eliminating the strep.
Okay. So what is the treatment for PSGN?
Symptomatic treatment.
Okay. So it's all symptomatic treatment. Okay. Okay. So kalau dia ada high BP, then you control the BP, you monitor the RP. Kalau dia ada acute kidney injuries ke, ataupun dia ada high urea ke, tiba-tiba renal function dia tak normal, and then oliguria and so on, then you probably need urgent hemodialysis. But normally there is a very rare occasion yang dia ada very severe kidney injuries. Most of the time PSGN is quite mild. It will disappear by itself. The thing is you just need to control the blood pressures. So it's a symptomatic treatment. The penicillin ataupun erythromycin that you give only for eradication of the streptococcal infection. It does not treat the PSGN. So this is the investigation for this case. The HB is slightly on the low side, but still within the normal range. The white cell is not raised. The platelet is normal, so this is no ITPs. The sodium, potassium is normal. The urea is slightly high. Is it quite common to see high urea in a post-strep AJN?
Yes, doctor.
Why is that?
Due to the leaking at the glomerula, due to the inflammation.
So leaking, inflammation. Tapi kenapa urea dia high?
Sorry, doctor. Due to inflammation at the glomerula, due to population of the messenger cell, so it will lead to reduce GFR. So the urea will be high.
Reduce blood flow. Okay, reduce blood flow to the glomerula. So basically, you will have reduced eGFR, right? So basically, your filtration of the blood supply to the glomeruli will be reduced. So basically, that akan reduce excretion of toxin from the body, especially the urea. So that's why you got high urea normally in post-strep AJN. The rest of them are quite normal. Albumin is normal as well. So this is not nephrotic syndrome. Clotting pun normal as well. The urine dipstick ada, blood 4+, ada protein, ada leukocyte, and also there is no nitrates. So how do you interpret this urine dipstick, and also there is microscopy of red blood cells and red cell casein as well. So So macam mana kita nak interpret this urine dipstick result?
There's a leukocyte is present, but there's no nitrates.
So
we can still diagnose as UTI because the presence of leukocyte. I'm not sure, doctor.
If leukocyte positive and nitrate positive, maksudnya macam mana? What is the meaning of that?
UTI.
Okay, UTI kan. Kalau either one, either leukocyte or nitrate positive, is it UTI?
Can be in the differential, doctor.
Okay, so normally kalau leukocyte or nitrate positive, you say that it's probable UTI. Kalau dua-dua positif, then you say that likely to be UTI. The UTI only be confirmed if there is blood adanya bakteria dalam urine culture, barulah kata confirm UTI. Okay. So in this case, dia memang ada hematuria kan, so there's blood there. But why there's a protein as well in the urine?
I'm not sure, doctor.
So basically it's the same as other condition lah. Sebab dia inflammatory process kan. Dia macam ada vasculitis. So kalau dia ada vasculitis, the blood vessels tend to be leaky. So kalau dia leaky, dia akan ada akan ada leaking of the red cells to the glomeruli, and also there akan ada a bit of protein yang ada leak as well to the urine. So because of the vasculitis, because of the inflammatory of the blood vessels, so that's why you got this leaking of protein and blood in the urine. So that's the expression of that. And leukocyte sometimes can be leaking as well. Tapi leukocyte compared to protein, compared to red cell, leukocyte is much bigger size. So that's why you got a slightly less. So you don't really expect leukocyte 4+ in glomerulonephritis. It tend to be very little. Either trace or 1+ or 2+, but you won't go more than that unless you got high leukocyte, maybe 2 or 3 with a nitrate, then with positive nitrate, then it could be the infections coming from the cystitis, not from the high macam pyelonephritis, not really from the glomerulonephritis. And so this is the interpretation of the urine dipstick. Okay. So the other thing you should do is you should do a throat swab for the streptococcal infection, as I mentioned before, but ASOTs, ESR, ANA, ultrasound scan for nak tengok ada kidney, ada stone or not lah, and also abdominal X-rays. Normally abdominal X-rays is not really helpful as well. The other thing you want to ask the mom is any past medical history of constipation, as you mentioned before. Okay, so kalau dia punya Bristol stool chart dia memang type 1, type 2, then likely that the child might have UTI, and then that cause the hematuria. The X-ray is helpful to tell the parents that this child got ada constipation. But apart from that, itu je selalu yang kita buat apa-apa. Okay, so in this case, it's most likely to be glomerulonephritis. Normally, it's happened about 2 weeks after the upper respiratory infection. Something it can associate with a degree of oligonuria with a renal failure. So in this case, dia ada raised urea kan, creatinine normal. So So as I mentioned before, yang Hafiz cakap tadi, dia akan ada reduce blood supply to the glomerulus, and then because of that, sometimes you can have reduced urine output. Normally, in the patient that we see in a very mild case, normally they don't really have much changes to their urine punya output. Normally kalau macam yang quite moderate to severe, ya baru betul-betul ada oliguria. Tapi most of the time, in the kidneys, the urine output is quite normal in a very mild case. Okay, so the other thing you want to make sure is this is the urine is the blood is not from the rectum, because if it's from the rectum, then this is not going to be urine problem. It's going to be rectal problem ataupun kalau dia ada constipation, because sometimes the constipation can cause the anal tear. Kalau dia perempuan, if this is menarche, then it's going to be something else. So it's not from the urine. So it's very important to know where exactly this blood coming from. Obviously, you need to think about possible abuse as well. So in any case, sama ada dia boys ke girls ke, you need to make sure that there is no element of abuse in the case. Kalau if you see any lot of bruises around the genitalia or around the anus and around the rectum, then think about sexual abuse. And remember that we're living in a sick society. Our society are so sick. So many cases of this kind of perpetual, unbelievable, unimaginable kind of criminal cases nowadays that we can't really imagine, how people can behave like this. So think about that. Walaupun it's not really common, but at the end of your mind, behind you need to make sure that you are thinking about this, looking for sign about this if there's any sign, so that you don't miss this physical abuse or sexual abuse. People say beetroots. I don't know what is beetroot really. I've not really eaten beetroots. Also can cause red urine as well. So it could be. Tak tahulah kalau Malaysia ni beetroot ni apa benda nama in Malay. And then I mentioned about hemoglobinuria, which is presence of hemoglobin in the red cells. It's also in the urine. So sometimes due to hemolysis. So sometimes if you got hemolysis reaction in your blood, it also can cause blood in the urine as well. Cuma if this is the case, when you do the red cell cast, there is no red cell cast in the microscopy, because it is not the renal causes for hematuria. Okay, so this is the list of differential diagnosis: UTI, nephritis, which is in this case, calculi, trauma, hematological problems, anatomical causes or malformations, tumors, medications, factitious illness. So this is one of the things that people made up the illness to get attention. Ataupun nama lain bagi factitious illness ni, nama dia adalah Munchausen syndrome by proxy, meaning that normally the child is normal, well, maybe parents ada mental issues, so the parents probably try to get attention from somebody. I don't know, maybe sort of psychological problems. So what they do is they made up the symptom. So the child probably have no hematuria. Cuma mak dia maybe ambil darah daripada mana-mana lah, ambil darah ikan ke, darah kambing ke, darah ayam ke, and put in the urine and come to hospital and says there is hematuria. Okay, so but the child otherwise normal, otherwise very well child. Cuma kadang-kadang in this factitious illness, you will find the child slightly dia punya growth dia slightly abnormal. It means that the child might have failure to thrive, might be slightly unkempt, might be slightly anorexic looking, and sometimes slightly nampak macam not well managed at home. So those probably a hint or signs that you might think about possible something wrong socially. So in this case, normally if you remove the child from the parent's care, the child get better, ataupun the child remains normal, remains well, and then there's no further no further symptom. Kalau in this case, kalau dia ada hematuria, so the child will have no hematuria if you remove the child care from the parents. As soon as the parents back and look after the child, and then the symptom will come back again. So those are very suspicious of factitious illness ataupun making up symptoms. Okay, I got a child who died a few years ago, where parents induced seizures. So when the child come to us, the child has a high sodium levels, almost 149 up to 165 per millimole per liter. And the urine dia pun nampak ada high concentration of sodium as well. Cuma dia punya osmolality dia not that high to diagnose diabetes insipidus. So we basically look after the child, and when we look after the child get better and better, and no further problems. The child go home, the child come back again with the same issues, high sodium levels. We do investigation, a lot of endocrine investigation, it's all come back normal. So we end up decided to remove the child care from the parents, get the child admitted to HTU or PICU for a while, and the child stays there for a couple of weeks and then remains well without any intervention or any treatments. And then because the child got better, and then we let them home again. So every time they got better, we let them home. So this thing happening about 4 to 5 times, and then we become very suspicious of factitious illness. And then at one point, we actually admitted this child, intentionally admitted this child into the we call it video room. Normally video room kita buat untuk video telemetry for EEG normally, but because of the suspicious of things, that we just intentionally tapi tak bagi tahu mak yang kita nak buat macam tu. So we put her into this videos room. Mak dia not aware of this room is a camera CCTV room. So we basically found out that mom has been injecting sodium into the IV fluids that lead to the high sodium levels. So we basically found that this child illness has been made up, has been induced, and then we basically found that both parents are basically has mental issues. So those are the thing, and the thing about factitious illness. And then recurrent benign hematuria, if once you rule out other things, and then it still keep happening, but the child looks normal, then you put the level as recurrent benign hematuria, because you couldn't find anything else that can cause the hematuria. So that's the things. Okay. So treatment for post-strep AGN is basically symptomatic treatments. You give antibiotics for eradication of the streptococcal infection. Otherwise, there's not much you do apart from monitoring the BPs. You advise for the low salt diet. If there is any edema, you probably need to manage edema by giving diuretics. And then you want to make sure that the urine output is getting better and better. If there is hypertension, then you start medication. Normally we use either nifedipine or amlodipine. And obviously, if there is very heavy proteinuria, then you need to think about possible kidney complication in this case. But most of the time, patient with post-strep AGN, you just manage them outpatient. Make sure the BP is controlled. Make sure their diet make sure they comply with their diets. And most of them make a full recovery with no poor prognosis. But obviously, you need to think about other differential as well to rule out, UTI, head-skull and purpura, and so on. Okay, so I'm going to stop sharing there, and then any question about this case? Okay, if there's no question about this case, then then somebody can do the second case. Boleh? Siapa buat second case?
Ni doktor.
Okay.
But can someone Haris project the slide for the second case? Right. For the second case. Okay. I will read the case first. Johan, an 18-month-old boy, was referred to community pediatric clinic because he is not yet walking. He was born at 41 weeks of gestation following an uneventful pregnancy. There was meconium staining of the amniotic fluid, but he cried immediately at birth and did not need any resuscitation. He has been generally healthy apart from normal cough and cold, and he had chicken pox at age of 6 months. His parents recalled that he could roll over at about 4 months, set up alone at 10 months, crawl from 13 months, and was able to bear walk on hands and feet and pull himself to standing from around 17 months. He can take a few steps holding onto the furniture and cannot walk independently yet. He is able to scribble with a crayon with either hand and can slot pieces into a shape, sorted toy. He uses lots of single word appropriately, understand simple instruction, feed himself with spoon, and will also feed his teddy bear. The parents have no concern about his vision and hearing. He attends nursery 3 days per week and is described by the nursery staff as a likely born, although they have been concerned that he still doesn't walk. There is no family history of delayed walking. Johan's mother is an accountant and his father is an architect, and both are in their early 40s. They are hoping to have another child soon. So, based on this case, anything that you guys need clarification, or we can go one by one to look at it, is this normal or abnormal?
Look one by one.
Right. Okay, first, okay, this is an 18-month-old boy, or about 1.5 years old. So basically, his presentation is delayed walking. Okay, born in 41 weeks, meaning that he is term or not, or premature? Okay, term. So there is no problem with the prematurity that might cause like cerebral palsy, right? Okay.
Yes.
Yes.
Meconium staining of the amniotic fluid. But then he did not need any resus, meaning to say what? Is there any problem with this condition?
No.
Maybe he didn't really have a problem. Meconium expression syndrome like that. Chicken pox at 6 months old. 6 months ago. 6 months ago. Is it normal for 1 year, 2 months?
1 year lah, 12 months. So
Okay, 1 year boy to have chicken pox.
you cannot say is it normal to have it, because you can have a chickenpox at any time.
Yeah. But okay. 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 Anything that you guys notice about any problem in this children, in this child? Okay. Basically about the walking. At age that actually a child can walk.
12 months old.
Independent.
12 months and above.
12 months and above.
Right. The median age at 12 months, right? And the limit age around 18 months. So this boy already reached 18 months but still cannot walk. So maybe something wrong with the delayed walking. Walking is one of the criteria in gross motor. How about the other developmental criteria like fine motor, speech and language? Any problem? Okay, if you look to the fine motor, scribble crayon with either hand, is there a problem?
Maybe it shows that the child still didn't have a hand preference because it can use both hands. But for normal fine motor, in 18 months, he should have hand preference.
Correct. Because hand preference is usually stabilized at age of 18 months. Okay, for other criteria in developmental milestone like speech and language, is there any problem in this child? He can use lots of single words and can understand simple instruction. I think he already achieved his milestone in speech and language. How about in social, emotional, and behavioral? I think there is no concern also.
There's no concern.
Yes. And okay. All right. So let's go. What you guys think? Possible diagnosis in this chart. Can anyone? Let us start with Haris.
Okay. For me, I think it might be due to a cerebral palsy because there is a meconium staining that include that he might be a problem. But however, he was not delivered at preterm, which is a risk factor for the cerebral palsy. And her mother also did not get any infection, so less likely to get any eventful event lah. So it might be less likely, and this case is cerebral palsy.
Alright.
But it can be a differential diagnosis.
Okay.
We're talking about differential diagnosis, isn't it?
Yeah. Yes.
I was thinking about muscular dystrophy, where there is a genetic mutation. So the thing is that one of some of the patient may have delayed working abilities, but ada yang normal, tapi it can be one of the differential diagnosis. Muscular dystrophy, maybe Duchenne, the most common one, Duchenne muscular dystrophy.
Okay. Any question that you would like to ask Peter to confirm this situation in the history?
I want to add to the Duchenne muscular dystrophy. How about how the child stand up? How about the Dover sign?
All right. And this child could have difficulty in climbing because tapi still delayed walking, right? Other than muscular dystrophy and cerebral palsy, any other differential diagnosis that you can guess of? I think. How about endocrine problem that can affect the development of the brain?
Hypothyroid.
Hypothyroid.
Yeah, it could be one of it because as we already learned just now that thyroid hormone thyroid ni important in promoting the growth and development of brain, right? Other than that, in
Can you say
nutrition,
about trisomy, any trisomy disease such as trisomy 21? So we could ask if the mother notice any dysmorphic feature
okay.
on the child.
Yes, we can. Before that, I just want to ask for this child, is it a global developmental delay or just a delay in walking?
I think delay in walking.
And just delay in walking.
Delay in walking.
Delay walking.
Right. Other than that, how about like rickets? Because in patient with rickets, he might have difficulty in walking, right?
Yes.
Any other differential diagnosis or any question that you would like to clarify further?
I just want to ask, can we just say that because there's only delay in the walking, right? We just say it's normal, just like for late learning, the child might have what we call it, because it's normal, but because the child late.
So you're talking about normal variants of late walker.
Yes, late walker. Yeah.
So in this case, so I just want to take over from you, Khadija, just for the developmental milestones. The first question was chickenpox at 6 months, 6 months ago, chickenpox at the 12 months old. Is it significant or not in this case? What do you think? So maknanya kalau 6 months tu umur dia 12 bulan kan? 12 bulan. So is it significant history for this HOPI?
For what?
For the problem ni lah. Mak dia kata, parents dia kata dia grow at 4 months old, dia sat alone at 10 months old, dia crawling at 13 months old, and able to bear walk ataupun pull himself up around 17 months old. So rolling at 4 months old, is it normal?
Yes.
Is it on time? Okay, that's okay. So sat alone at 10 months old?
Yes.
It's a little bit late ke doktor? Sebab kalau dalam buku Nelson's Essential tu dia cakap at 6 months.
Okay, so it's probably late then. Okay. So the sitting up, there is two type of sitting up. Satu sitting up with a curve back, ataupun curve back kan. Dia punya belakang dia macam curve ataupun curve kan. Itu about 6 months old. And then by 9 months old, they should be able to sit up alone with a straight back. So there's two stage of sitting up. Okay. And they're crawling at 13 months old. Crawl at 13 months old. So is it okay? Is it delayed? Is it on time?
Like a bit delay. Should start at 6 months. Nine.
So crawling should happen earlier. So as soon as you are sitting up, then you expect the child should be crawling as well. So kalau they stay up by 6, 7 months, 6, 7, 8, then they should be able to crawl by at the age as well. So about 7, 8 months old as well. And then once you start crawling and once you start have a good upper limb strength, then you are able to basically stand up by yourself. So normally by 10, 11, children start to pull themselves up and then standing up with support. Okay, obviously most of the child you expect them to walk by the age of 18 months. So in this case, dia cuma starting to stand up around 17 months. Tapi 18 months ni dia still lagi not walking. So it is a red flags. Okay, that's one about dia punya gross motor kan. And then dia punya fine motor dia. Fine motor dia basically dia scribble with a crayon with either hand. Mana dia tak develop lagi dia punya hand preference kan. So hand preference you expect what age?
1 year, about 12 months.
About 12 months
Okay.
hand preference.
18 months.
18 months
18 months.
18 months Okay, so you expect the child should start to develop hand preference after 18 months. So before 18 months, kalau ada hand preference before 18 months, then you need to think about possible CP. Okay. Normally hand preference start later, dalam 2-3 tahun baru start hand preference. So before that, they can just use either hand to scribble. Okay. So hand preference is starting to develop after 18 months old. If they start before 18 months old, then you need to think about possible cerebral palsy. The reason that I think about CP is because they got weaknesses on the one side. Ni kalau dia hemiplegia, they got weaknesses on one side. Because of the weaknesses on one side, they use the one yang tak weak untuk buat everything lah. So nak menulis ke, nak ambil toys and so on. So if they start using one side and the other side is not being used, then you are worried about that. Okay. So in this case, nothing much in terms of dia punya fine motor, and then obviously he can do the slot piecing slotting pieces into the shape sorted toys. Dia boleh makan sendiri. Ada maknanya dia punya upper limb dia okay lah. No issues with the upper limb, no issue with the vision and hearing. Okay. And then dia macam socially looks okay je, pergi nursery and so on. Cuma this age still lagi tak berjalan. So those are the main concern at the moment. The other thing is about in this case is both parents are in the early 40s. So in the early 40s, you are worried about possible trisomies, and either whether it's a very mild trisomies of 21. Or tapi kalau you talking about trisomy yang 18 ke, yang 13 ke, normally they are not well by the age. Normally they will basically pass away already by this age. So I'm putting down there the examination findings on this case, so you guys can have a look at the finding. So this is the physical findings. So it looks okay. So it looks not dysmorphic. Weight they're okay, 10.8 kilogram. Height there, 80 centimeter, which is fine. Head circumference pun okay lah, 49. Ke tak okay head circumference ya? 25th centile weight and height. And then the head circumference 49, 50th centile. Is it okay or is it not okay?
It's okay.
It's okay, eh? Otherwise, examination point of view, nothing much on the examination. Nothing much on the examination there. Cuma it mentions that when he is helped to stand, he basically need to hold the side to take a few steps, and then dia pakai dua-dua tangan untuk supporting dia punya step, meaning that he's not really be able to walk independently, kan? So what you want to do? What other examination you want to do? Hello? Tak dengar eh?
Yes, Doctor.
Yes, Doctor. Yes, Doctor.
Okay. So Khadijah, so what other examination you want to do?
Sorry, Doctor. I'm not sure.
Tak dengar? Huh? Hello?
Yeah,
Outside?
Medical examination, since it is already normal, it could rule out cerebral palsy in spasticity, because there is no hyperreflexia, hypertonia.
Okay, so tone dia okay, power dia okay, reflexes okay, posture pun okay, so it's not CP, okay? Wow.
For myotonic dystrophy, I'm not sure about the test, but we can ask the child to stand up to look the way of any Gower sign.
Okay, so how are you going to ask the child to do a Gower sign for you?
From the prone position.
Macam mana?
The child.
Macam mana kita nak suruh dia buat Gower sign? Apa instruction yang you want to give to the child to do?
First, the child has to sit and how to stand up.
So, sit tu macam mana?
Kaki dia melunjuk ke? Salah tak?
Melunjuk. So that's two way you can do, okay? You can ask them to sit macam apa, duduk bersila macam biasa. And then ask them to stand up, and then ask them to stand up without any help. Mana dia tak boleh pegang meja ke, tak boleh pegang kursi ke untuk dia bangun. That's one. The second way you can do it, you can ask them to squat. Mana duduk bertinggung kan, apa nama bahasa Melayu?
Cangkung.
Cangkung, yes, duduk cangkung. And then ask them to stand up from the squatting position and stand up without any help. Mana dia tak boleh ngelak lah, dia tak boleh pegang meja, pegang kursi untuk support. And dia kena bangun sendiri. So normally if they got proximal myopathy ataupun lemah dia punya weaknesses of the central tone ataupun weaknesses of the limb girdle, then you can see the Gower sign atau Gower movement tu. Maknanya dia macam climbing up to stand up and using compensating dia punya limb girdle weaknesses. So those are the thing that you ask them to do. Okay, so we mentioned about Johan punya developmental milestone. For the assessment, let's say not much really. And then the most important investigation you want to do. What is the most important investigation you want to do?
Could be serum creatinine kinase.
Okay, so that is it the most important?
Or brain MRI.
Brain MRI. So why you want to do brain MRI?
To rule out any brain lesion like periventricular leukomalacia.
But why you want to rule out PVL, periventricular leukomalacia?
In the case of cerebral palsy.
The physical finding is normal, right?
Oh, okay.
And there is no hypertonia, there is no hyperreflexia, there is no weaknesses. And
yes.
So why you want to do MRI? So what is the indication for MRI? So well, at the moment there's no indication for MRI, kan? Betul tak?
Yes.
Okay. So I think you guys kind of like knowing what's the issue here, and this is a child with proximal myopathy, and so proximal myopathy, the most common cause proximal myopathy in a boy is going to be Duchenne muscular dystrophy, betul tak?
Yes.
Duchenne muscular dystrophy, yes, you do CK, but CK is not the diagnostic investigation.
Muscle biopsies.
So you want to do muscle biopsies, and so those are the most important investigations to perform, to do. Obviously, yeah, you will do the blood count, you will do the RP, LFTs, you will do the lactate, blood gas, and so on. And tapi those investigation, some of them will be positive, but it's not going to give you the information ataupun it's not going to help you to come to the diagnosis, and dia cuma akan bagi give an idea. So if you do a CK, if this is muscular dystrophy, the CK will be high. Cuma you still it's not a gold standard for proximal myopathy. Okay. So you still need to do further investigation to basically confirm the diagnosis, which is the muscle biopsy. Yeah, 2 seconds. Okay, so obviously kita tahu dia punya developmental milestone dia ada isolated gross motor delay. We know that he's rolling at the normal age, 4 months old is normal age. Cuma dia crawling tu late lah. About normally crawl you should able to crawl the age of 9 months normally. Walking should be earlier than that. So not walking by 18 months is a red flag. So that's why you need to investigate this child, and obviously you do other testing as well before you come to before you with mana nak kena asal dia punya fine motor, speech dia, language dia, social dia as well. So in this case, we'll do the CT, CK. So CK normally high in muscular dystrophy, and because this is a boy, so we are thinking about Duchenne. Okay, and Duchenne normally has high CKs. The reason that they have high CK is because that the muscles is being consistently, persistently, daily, every moment they inflame and got destroyed. So that's why the CK is high because of that. And because parents want to have another child, so they need to have a genetic counseling, because there's a risk of the child being affected if the child is a boy. And obviously it's a X-linked recessive, so the mutation is coming from the mom. So most of the child, the Duchenne, they have progressive muscle weaknesses. Some of them will end up bedridden, wheelchair bound by early teenagers or early teen if they're not being managed properly. So most of them kita akan start dengan steroid for to control or try to slow the progression of the muscle weaknesses, and hopefully they can walk as long as possible. Most of them basically die not because of the immobility. They die because of sometimes they need NIV, non-invasive ventilation, because they got poor muscle, poor chest, poor respiratory muscle punya strength. So most of them might not have a good lung function, might have recurrent respiration and so on. And some of them might have a degree of learning difficulties. Why children with Duchenne has learning difficulties?
They have proximal muscle weakness.
Tapi kenapa dia ada learning problem? Kenapa dia tak boleh nak belajar? Ataupun susah nak belajar?
Because the affected gene, which is a dystrophin, sometimes it is one of the function is for brain development, and
so basically you got dystrophin in your brain as well. So that's why if you got dystrophin is absent in your brain, it will affect your learning as well, your learning ability as well. It's different compared to kita panggil spinal muscular dystrophy ataupun spinal muscular atrophy, because it's affecting the spine and it's affecting the muscles. For Duchenne, it's affecting the dystrophin gene, and dystrophin gene is everywhere in your body, in your muscles, in your livers, in your heart, and also in your brain as well. So that's why children with Duchenne muscular dystrophy, you will see a degree of learning problem. There might be childish behaviors, so and their IQ normally average. So maknanya kalau if in a school, kalau school tu ada 10 kelas, maybe they are on the bottom half, probably on the kelas nombor 7 ke nombor 8 ke. So that's because they have learning difficulties as well.
Hello. Doktor? Doctor?
Dr. left.
Sampainya hatimu.
Left lu.
Record.
Astaghfirullahaladzim, tak pasal.
Hampir 4 jam record.
Gurau je.
Hello, Cik Ngam. Sorry guys. My house got blackout. Elektrik tak ada. So wifi dah mati. So where was we?
Learning difficulty.
Okay, difficulties. Okay, so basically korang missing 2 slide. I was talking by my own just now kan. Okay. I'll go back. Tiba-tiba tak ada api pula loh. So basically, I need to do it quickly because my battery is running out now. So some of them will have developmental delay and also learning difficulties. Is mainly because of the dystrophin also in the brain as well. Your dystrophin gene is in your brain, in your muscles, in your livers and so on. So if you got dystrophin problems, then it's going to affecting your learning as well, because you're losing your dystrophin in your brain. Compared to the spinal muscular atrophy, because it's only affecting the spine and also muscles, so it's not really affecting the brain. So most of the patients yang ada SMA, spinal muscular atrophy, they have no learning problems. Their IQ is normal. Okay, so So most of the child yang ada walking difficulties, most of them are just a normal late walker. So but you still want to investigate them if they're not walking by 18 months. So you still want to make sure that you've done what you need to do. If they have muscular proximal myopathy, you want to do the CK, and also you want to do the muscle biopsies. If they have hypertonia, hyperreflexia, then you want to make sure that you are ruling out the CPs. If they have dysmorphic features, then you want to do the karyotyping, and also might want to do the genetic assays and so on. And obviously, if you're talking about hips problem, then you do the X-rays and then refer to the orthopedic surgeon for interventions. But most of them who are not working by 18 months, or 90 patients out of 100 patients who are late worker, they are basically normal late worker. Okay, so the summary for this case is failure to walk by the 18 months old is a warning sign, so you need to investigate. And I would say the Duchenne is important diagnosis, especially in boys, to exclude. So if somebody is not walking by 18 months, they have proximal myopathy sign, which is a Gower sign, you really want to make sure that you're ruling out Duchenne muscular dystrophy. The reason for that is because the sooner you start on steroids, then you can in fact prolong their ability to walk. Okay. Because the steroid will reduce the inflammation of the muscles, because your muscle has been constantly being destroyed, has constantly been breaking down. So the steroid will help to maintain the power, the muscle strength of the strength of the muscles, and then that will prolong the mobility, and sometimes it will also prolong the lung function as well. So because most of them basically die because of the immobility, they die because of the cardiomyopathy and also poor lung compliance or poor lung functions. Okay. Question about this case? Akan habis cepat bateri nak habis. Any question?
No, Doctor.
Okay, no question. Okay, fine. If there's no question, I think I can adjourn our session. It's Friday. Semua orang nak ni. Aziz dah makan dah. Tak apa lagi dah makan dah. Okay lah. Tak ajak orang makan. Okay, fine. Tapi minum air dia. Saya ingat apa minum air dia. Aisyah minum air dia kan. Aisyah minum air dia. Okay, semua orang get ready to go for lunch. Okay, so that's it. If there's no question, then we're going to adjourn our session. We start with the first one last. Okay, thank you very much. Assalamualaikum warahmatullahi wabarakatuh.
Thank you, Doctor.
Thank you, Doctor.
Thank you very much.
Thank you, Doctor.